بسم الله الرحمن الرحيم. هنبدأ إن شاء الله بإذن الله شرح البروتوكول الجديد اللي بقى كوفيد بعد وزارة الصحة.
Page number summary of changes in the new protocol. Triage. Severity assessment. Management protocol. Post-hospital discharge medications. Post-acute COVID syndrome. Mucormycosis co-infection in COVID-19 patients.
طيب ده الايتمز. هنبدأ إن شاء الله بإذن الله. ده
Summary of changes in the new protocol. 1. Supportive multivitamins are optional in the management of cases. 2. Monoclonal antibodies therapy may be considered in the management of moderate cases. 3. Favipiravir plus ivermectin combination in moderate cases.
طبعا الرقم 3 ده جديد.
3. Favipiravir plus ivermectin combination in moderate cases. 4. Prophylactic anticoagulation in moderate, severe and critical cases. Therapeutic anticoagulation only if indicated for another reason irrespective to D-dimer level. 5. Colchicine may be used as anti-inflammatory and immunomodulator in moderate, severe, and critical cases.
طبعا احنا عندنا في العزل بتاعنا في مستشفى قوس بنعالج حالات مودريت مايل تو مودريت، ما بنستعملش حالات سيفير يعني.
5. Colchicine may be used as anti-inflammatory and immunomodulator in moderate, severe, and critical cases. 6. After day 12 of infection, antivirals are used beside anti-inflammatory drugs. 7. Adding seralutinib if tocilizumab is not available. 8. If the patient is maintaining good oxygen saturation but with high respiratory rate on oxygen therapy, it is wise to shift to either HFN, NIB or CPAP to decrease mortality, and if still distressed, shift early to invasive mechanical ventilation. 9. Management of mucormycosis. First step.
هنبدأ إن شاء الله بإذن الله first step triage.
First step. Triage case definition plus severity assessment. Suspected case definition A. Clinical and epidemiological criteria. B. Acute onset of fever and cough. Acute onset of fever and cough is greater than or equal to 3 of the following: fever, cough, general weakness, fatigue, headache, myalgia, sore throat, coryza, dyspnea, anorexia, nausea, vomiting, diarrhea. Altered mental status and one of the following within 14 days and one of the following within 14 days of symptom onset of symptom onset plus. Residing or working in an area with high risk of transmission * residing or travel to an area with community transmission working in a healthcare setting probable case. B. Patients with severe acute respiratory infections defined as acute respiratory infection with symptoms within 10 days of presentation, cough, fever, and hospitalization.
طيب هنخش على
residing or working.
cases دلوقتي.
A patient who meets clinical criteria and is a contact of a probable or confirmed case, or epidemiologically linked to a cluster with at least one confirmed case. OR suspect case with chest imaging showing findings suggestive of COVID-19 disease * OR. Recent onset of loss of smell or taste in the absence of any other identified cause or unexplained death in an adult with respiratory distress who was a contact of a probable or confirmed case or epidemiologically linked to a cluster with at least one confirmed case. * hazy opacities with peripheral and lower lung distribution on chest radiography. Multiple bilateral ground glass opacities with peripheral and lower lung distribution on chest CT. Or thickened pleural lines, B lines, are consolidative patterns on lung ultrasound. Confirmed case. A person with laboratory confirmation * of COVID-19 infection, irrespective of clinical signs and symptoms.
دي اللي هي المسحة
* molecular testing with deep nasal swab is the current test of choice for the diagnosis of acute COVID-19 infection. Severity assessment suspected case. PCR-TO confirm the diagnosis * assess disease severity. Mild symptoms normal imaging. Imaging plus VESPO is greater than or equal to 92%. SPO2 less than 92%. POW2 PO2 less than 300. Respiratory rate greater than 30 breaths per minute. Or lung infiltrates greater than 50% respiratory failure, septic shock, and or multi-organ dysfunction.
mild moderate severe
Admit to intensive
critical
care. Admit to intermediate care hospitals. Admission COVID area home isolation and close follow-up if possible. Less than 65 years old and no uncontrolled
mild
comorbidity.
moderate طبعا home isolation.
Critical illness ever. Moderate mild. Risk factor plus yeast no.
طيب هنشوف دلوقتي
In severe and critically ill patients, if they first PCR, repeat within 48 hours. Negative cases considered after 2 consecutive RT-PCR results from respiratory samples tested at least 1 day apart.
واضحة دي.
NB. Unstable patient who don't meet the suspected criteria should receive first aid therapy in non-COVID area before referral to general hospital. Plus risk factors include old age is greater than or equal to 65 years, uncontrolled comorbidity is hypertension, DM, or social unapplicable to home isolation. All persons with suspected, probable or confirmed COVID-19 should be immediately isolated to contain the virus transmission.
هنشوف دول
Simplified case definition. Simplified case definition. 1. Mild, no pneumonia, no hypoxia. 2. Moderate, pneumonia without hypoxia. 3. Severe, pneumonia with hypoxia responding to oxygen therapy. 4. Critically ill, pneumonia with hypoxia not responding to oxygen therapy and or organ dysfunction. Second step. Management. Patients with symptomatic COVID-19 and risk factors for progression of disease should be closely monitored. In some patients, the clinical course may rapidly progress. Timing is an important issue in the management of COVID-19. Before day 12, antiviral drugs are essential. After day 12, the role of antiviral drugs declines with augmentation for the role of anti-inflammatory, immune modulators. There are insufficient data to recommend either with or against any antiviral drug or immune-based therapy in patients with COVID-19 who have mild illness.
طبعا الخطوة دي جديدة ما كانتش قبل ما كده.
Potential antiviral drugs under evaluation for the treatment of COVID-19 include hydroxychloroquine 400 milligrams, 12 hours first day followed by 200 milligrams, 12 hours for 6 days. Ivermectin 36 milligrams on day 0, 3, 6. Favipiravir 1600 twice daily in the first day, then 600 milligrams twice daily. Remdesivir 200 milligrams IV on day 1, followed by 100 milligrams IV daily for high-risk population for 5 days that could be extended to 10 days if the response is unsatisfactory. Monoclonal antibodies. In moderate cases with as greater than or equal to 3 risk factors. Convalescent plasma. For impending severely ill after counseling the scientific committee. Antibiotics are not recommended to prevent bacterial infection in mild or ordinary patients. Administer empiric antibiotics if bacterial pneumonia, sepsis strongly suspected. Re-evaluate daily. In hospitalized patients, do not initiate therapeutic anticoagulants or antiplatelet unless other indications exist.
طيب هنخش
mild case.
هنشوف المايلد cases.
1. Age 2. Temperature greater than 38.3. SAO is less than or equal to 92%. 4. Heart rate is greater than or equal to 110.5. Respiratory rate is greater than or equal to 25 per minute. 6. Neutrophil lymphocyte ratio on CBC is greater than or equal to 3.17. Uncontrolled comorbidities 8. Immunosuppressive drug 9. Pregnancy 10. Active malignancy 11. On chemotherapy 12. Obesity. Check 4. Any yes or no. Age less than 60. Strict home isolation. Follow and use personal protective guide equipment. If any deterioration occurs, back to hospital. NB. Paracetamol is the preferred antipyretic. If any yes or no. Age is greater than or equal to 65. If more than 3 risk factors admit. Treatment. Hydroxychloroquine or ivermectin. OR favipiravir 1600 twice daily in the first day, then 600 milligrams twice daily for 5 to 10 days. Plus or minus supportive multivitamins.
تمام. نشوف المودريت cases.
Hydroxychloroquine. Patients with pneumonia and without hypoxia. Moderate. Patients with pneumonia and without hypoxia. Moderate case. Anti-inflammatory.
لا لو
Age is
انتي
greater.
فايرال.
Antivirals. Hydroxychloroquine. 400 milligrams twice in the first day, then 200 milligrams twice daily for 6 days plus ivermectin. 36 milligrams on day 036. Favipiravir. 1,600 milligrams twice daily first day, then 600 milligrams twice daily for 5 to 10 days plus ivermectin. 36 milligrams on day 036.
والريميديزيفير.
Remdesivir. For high-risk patients with SAO2 is less than or equal to 94,200 milligrams in the first day, then 100 milligrams daily for 5 to 10 days.
الانتي انفلاماتوري.
Anti-inflammatory. Age is greater than or equal to 65 years. RR greater than 24 or CT scan showing rapid deterioration. Dexamethasone 6 milligrams or its oral equivalent.
والكولوشيسين.
Colchicine. 500 micrograms, 12 hours for 1 month.
طيب الاميون.
Immune modulators convalescent plasma. Could be used before day
طبعا
12.
دي مش من عندنا احنا.
Monoclonal antibody therapy. May be used if available in moderate
cases.
patients with greater than 3 risk factors * of progression to severe form. Parenteral prophylactic.
الانتيكواجولانت طبعا.
Immune modulators anticoagulation. Parenteral prophylactic anticoagulation. Enoxaparin 0.5 milligrams per kilogram per day. Adjust prophylactic dose if body weight greater than 70 kilograms. Therapeutic anticoagulation only if indicated for another
المحاضرة دي أنا
reason.
هعملها عشان إن شاء الله بإذن الله
Favipiravir. 1,000. Age is greater than or equal to 65 years. BMI is greater than or equal to 35. Comorbidities, malignancy, immunosuppression.
هنخش دلوقتي على السيفير كيسز.
Severe cases. Immunomodulators.
لا سيفير كيسز سوري.
If any of the following criteria is met.
تمام.
Critically ill if.
ايه الكرايتيريا بقى؟
1. RR greater than 30.
تمام.
2. SAO2 less than 92 at room air 3. PAO2 PO2 ratio less than 300. 4. Chest radiology showing more than 50% lesion or progressive lesion within 24 to 48 hours. Severe cases. Admit to intermediate care.
الانتيفايرال.
Anticoagulation anti-inflammatory. 1. Remdesivir for high-risk patients with SAO2 is less than or equal to 94,200 milligrams in the first day, then 100 milligrams daily for 5 to 10 days. Steroids methylprednisolone tocilizumab 4 to 8 milligram per kilogram per day for 2 doses 12 to 24 hours apart, or serolumab 200 milligrams single dose colchicine 500 micrograms 12 hours for 1 month. Convalescent plasma can be used before day 12. Parenteral prophylactic anticoagulation. Enoxaparin 0.5 milligrams per kilogram per day. Adjust prophylactic dose if body weight greater than 70 kilograms. Therapeutic anticoagulation only if indicated for another reason. Antivirals. Contraindication for using anti-IL-6. Bacterial infection. ANC less than 500 cells per cubic millimeter. Plat, less than 50.000 cells per cubic millimeter.
بتأثر في نسب النجاح.
Alt greater than 5x ULN. If any. Critically ill patients.
دول بقى مش موجودين عندنا.
Admit to intensive care. Remdesivir 200 milligrams in first day, then 100 Critically ill if. SAO2 less than 92, ORRR greater than 30. And PAO2 PO2 ratio less than 200 despite oxygen therapy and or additional organ dysfunction. Critically ill. Admit to intensive care. Remdesivir 200 milligrams in first day, then 100 milligrams daily for 5 to 10 days.
شايفين الاختلاف؟
Steroids methylprednisolone. Tocilizumab 4 to 8 milligram per kilogram per day for 2 doses 12 to 24 hours apart, or serolumab 200 milligrams single dose. OR colchicine. 500 micrograms, 12 hours for 1 month. Parenteral prophylactic anticoagulation. Enoxaparin 0.5 milligrams per kilogram per day. Adjust prophylactic dose if body weight greater than 70 kilograms. Therapeutic anticoagulation only if indicated for another reason. Antivirals. Anticoagulation anti-inflammatory.
طيب هنخش دلوقتي على حاجة كده يعني هم كانوا عاملينها الانفيزيف والنون انفيزيف. طبعا احنا هناخدها
Seralutinib 200
من باب
milligrams
العلم
early block
الشائع.
the storm if steroids failed. Antiviral drugs in severcases. Steroid. Tocilizumab 4 to 8 milligram per kilogram dose OR. Antiviral drugs in severcases. Avoid hypoSHAO2. Avoid hypoSHAO2 NIV HFNC IM.
الستيرويد
Steroids. Methylprednisolone 1 to 2 milligram per kilogram D prophylactic parenteral anticoagulation pronawake or ventilated. Avoid hypoSHAO2 NIV HFNC IMV if needed add antibiotics. 1 milligram for non-ventilated and 2 milligrams for ventilated. If the patient is maintaining a good oxygen saturation but with high respiratory rate on oxygen therapy, it is wise to shift to either HFN, NIV or CPAP to decrease mortality and if distressed, shift early to invasive mechanical ventilation. Conscious patients with minimal secretions. Hypoxia SPO less than 90% on oxygen, or PACO2 greater than 40 millimeters of mercury provided pH 7.3 and above. NIV trials shall be short with ABG 30 minutes apart. Any deterioration in blood gases from baseline or oxygen saturation or consciousness level shift to IMV. CPAP gradually increased from 5 to 10 cm H2O. Pressure support from 10 to 15 cm H2O. HFNC can be alternative to NIV. Consider ROX index for HFNC. Non-invasive ventilation or high-flow nasal cannula. Use PPE including goggles during intubation and avoid bagging. Invasive mechanical ventilation. Failed NIV are not available or not practical. POW less than 60 millimeters of mercury despite oxygen supplementation. Progressive hypercapnia. Respiratory acidosis. Progressive or refractory septic shock. Disturbed consciousness level or deterioration in consciousness level from baseline. Indications.
بيقول لك جاست ان انت اقل من 8 تيب على طول، اقل من 8 تيب. تمام، الحته دي اهي.
Disturbed consciousness level or deterioration in consciousness level from baseline. Indications. Plateau P less than 30 cm Hoinkrem.
القاعده دي
Disturbed consciousness level.
خدناها اللي هو ايه، just 8 Glasgow scale كوما just 8 intubate. احفظوها كده just 8 intubate.
Initiation of invasive mechanical ventilation step 1. VCVTV 8 milliliters per kilogram peak 5 cm H2O. Plateau pressure. Less than 30 cm H2O sat greater than 93 keep and watch. Less than 30 sat less than 93 increase peak to 10. More than 30 ARDSNet protocol.
طبعا
inspiratory pause for 1 second.
طيب هنخش بعد كده على step 2.
If plateau above 30 cm HO. Use PPE including goggles. Shift to ARDSNet protocol if needed. Step 2. ARDSNet protocol. Low TV 6 to 4 milliliter per kilogram. Driving P less than 15 cm HO. Start with tidal volume of 6 milliliters per kilogram to keep plateau pressure on volume-controlled ventilation below 30 cm H2O. Decrease to 4 milliliters per kilogram if the plateau remain higher than 30. Allow permissive hypercapnia so long the pH is above 7. 3. Compensate by increasing respiratory rate up to 30 breath minute. Consider heavy sedation and paralysis. If pressures are higher, any evidence of barotrauma, shift to pressure-controlled ventilation and be cautious about low tidal volume alarms for fear of unnoticed endotracheal tube obstruction. Consider ECMO early if eligible. Increase PEEP gradually if the patient remains hypoxic according to FiO2 level to keep driving pressure less than 15 cm H2O. Never forget prone position. Assessment of rest.
prone position مهم طبعا. انت هتقول لي انت بتشرح الحاجات دي ليه دلوقتي؟ الحاجات دي تتذاكر علشان ممكن يجي لك انتداب في مستشفى عزل زي ما حصل عندنا في أسوان الصداقة. جابوا ناس من الزمالة ودوهم انتدابات في مستشفى الصداقة، فانت هتكون في وش المدفع تتعامل معاه فينت وحاجات ارقام وحاجات دي لازم تكون مذاكرها كويس.
Assessment of respiratory support outcome. Step 3. Improved weaning of respiratory support. Assess ABGs, clinical radiological. Stationary continue respiratory support is needed. At deteriorating criteria for ECMO asterisk. High velocity nasal insufflation. Asterisk criteria for VVECMO. Age below 49. Mechanical ventilation duration less than 72 hours. No comorbidities. Preserved conscious level. POW2 PO2 less than 100 despite prone resp score greater than 0. Expert opinion is needed and depends on availability. Deteriorating criteria for ECMO asterisk.
الهاي فيلوسيتي طبعا نزل. الهاي فيلوسيتي
High velocity nasal insufflation.
برضو بيستخدموه في
High velocity nasal insufflation, a form of high flow nasal cannula, focuses on optimum efficiency of the dead space purge to augment ventilation, in addition to providing other effects of high flow nasal cannula. High VNI technology has a simple nasal cannula that delivers warm, humidified gas, and doesn't seal to the face. While being treated, patients can talk, eat, drink, and take medication. It is a frontline tool for respiratory distress including hypoxemia, hypercapnia, and dyspnea. Mask-free NIV for spontaneously breathing patients, and offers ventilatory support as an alternative to NIPIV for treating undifferentiated respiratory distress. The nasal cannula used with high VNI technology is comfortable for patients and reduces the risks and care complexities associated with mask therapies. High VNI is a first-line therapy for COVID-19 hypoxemic PA. High VNI is a first-line therapy for COVID-19 hypoxemic patients. TNs. High VNI technology and WAB reduction. High VNI technology and WAB reduction. The fact that small bore cannulas reduce the time required to fully purge the upper air bore cannulas reduce the time required to fully purge the upper airway dead space is significant because as the respiratory rate of a way dead space is significant because as the respiratory rate of a patient in respiratory distress increases, the time between breaths patient in respiratory distress increases, the time between breaths decreases. By quickly clearing the upper airway dead space of end X decreases. By quickly clearing the upper airway dead space of end expiratory gas rich in CO2, high VNI technology helps patients breathe paratory gas rich in CO2. High VNI technology helps patients breathe directly from a fresh gas reservoir and thereby reduces their WAB. Direct.
طبعا زي ما قلت لكم ان انت تكون مؤهل لان ممكن يبقى يجي لك انتدابات في الفترة المجربة اللي تبدأ محدش عارف، فانت تكون مؤهل ان انت تكون تتعامل مع البروتوكول. علشان كده احنا بننزل المحاضرة دي صوتية، بنساعد على قد ما نقدر.
Monitoring of patients on HFNC. ROX index. F102, respiratory rate. Example. SPO2 equals 98. FiO2 equals 75%. RR equals 25. ROX equals 98 over 0.75 equals 130.667. 25 equals 5.2325. To be done after 1, 2, 6, 12 hours from starting HFNC and then every 12 hours. Score. Greater than 4.88, 3.85, 4.87, 2.85, 3.84.
الجدول ده يتحفظ برضه.
If in green, 2 to 3 consecutive. If in green zone, continue on HFNC.
تمام.
2 to 3 consecutive records in orange zones, shift to CPAP. If at any time in red zone, intubate.
هنخش على
Target SPO2.
هنخش على
Oxygen therapy. Parameter. Value. Target SPO2 is 92 to 96%. Start oxygen therapy once SPO2 less than 92%. Once oxygen is required, the patient is indicated for awake proning. Remdesivir is an antiviral therapy. Steroids. Prophylactic anticoagulation 1. Nasal cannula. 1 to 6 L per minute gives 0.240.4 FiO2. Face
طبعا دي
mask.
أنواع الماسكات.
5 to 10 L per minute gives 0.350.6 FiO2.
Inventory
Non-rebreather mask.
احنا ما عندناش غير الفيس
10 to 15 L per minute gives up to 0.9 FiO2. Venturi mask.
Venturi mask.
4 to 15 L per minute gives 0.240.6 FiO2. High flow nasal oxygen therapy. HFNC.
ده
High
في
VNI.
العنايات.
Oxygen therapy.
والسباب طبعا.
Parameter. 6. CPAP BiPAP. Monitoring of patients on CPAP. HACOR score. Antibiotics in COVID-19 indications. Rapid development of
طبعا الجدول ده برضو السباب ده برضو شغل عنايات يعني.
Antibiotics in COVID-19 indications. Rapid development of consolidation pattern. Development of lobar consolidation. Leukocytosis with absolute neutrophilia. Reappearance of fever after afebrile days.
antibiotic مهم جدا.
Increased CRP with improved other markers as ferritin. Procalcitonin is highly specific. Low risk in patients. Combination therapy. Beta-lactam plus either a macrolide or doxycycline. Monotherapy. Respiratory fluoroquinolone high risk in patients. Beta-lactam plus a macrolide or fluoroquinolone is recommended. 1. Anticoagulant.
أخيرا بقى
1.
hospital discharge.
Post-hospital discharge medications. Definition and incidence. Definition and incidence. 1. Anticoagulation. 1. Anticoagulation. Used in high-risk patient. Age greater than 65. BMI greater than 35. Malignancy. Immunosuppressed. Previous VTE. Use. A. Enoxaparin 40 mg SC once daily, ORB. Apixaban 2.5 mg twice daily, ORC. Rivaroxaban 10 mg once daily. 2. Colchicine Tab 2. Colchicine Tab 500 mg twice daily. Post-hospital discharge. Post-acute COVID syndrome. Management. Definition and incidence. Definition and incidence.
Post-acute COVID syndrome.
In the absence of agreed definition, it may be defined as patients not recovering for several weeks or months following the start of symptoms that were suggestive of COVID, whether patients were tested or not. It may extend beyond 3 weeks from the onset of first symptoms up to 3 months, sometimes occurring after a relatively mild acute illness. If symptoms are extending beyond 3 months, it is termed chronic COVID. In short, despite their illness being over, they are having a lot of trouble returning to normal life. It occurs in around 10% of patients. Patients can be divided into those who may have serious sequelae and those with a non-specific clinical picture, often dominated by fatigue and breathlessness. One last group of COVID-19 patients whose acute illness required intensive care management. Post-acute COVID syndrome. Management. It's a multidisciplinary management. Specialist referral may be indicated based on clinical finding, for example. Respiratory. If suspected pulmonary embolism, severe pneumonia. Cardiology. If suspected myocardial infarction, pericarditis, myocarditis or new heart failure. Neurology. If suspected neurovascular or acute neurological event. Pulmonary rehabilitation may be indicated if patient has persistent breathlessness. Medical management. Symptomatic. Treating fever by paracetamol and NSAIDs. Management of comorbidities including diabetes, hypertension, kidney diseases and ischemic heart diseases. Consider antibiotics for secondary infection. Treat specific complication as indicated. Psychological support. Self-management. Daily pulse oximetry. Attention to general health like good diet, good sleep
أنا
hygiene,
الحاجات دي بطبقها أنا بعد الإصابة
quitting
بتاعتي.
smoking, limiting alcohol, limiting caffeine, rest and
على قد ما أقدر
relaxation,
يعني.
self-pacing and gradual increase exercise. Set achievable targets.
طيب هنخش إن شاء
Aspergillosis,
الله أخش على حاجة اللي هي دي
mucormycosis co-infection in
حاجة رير يعني.
COVID-19 patient. Mucormycosis, Aspergillosis and Candida have been reported as the main fungal pathogens for co-infection.
ولكن الفطر الأسود والفطر الأبيض.
Several cases of mucormycosis co-infection have been increasingly reported worldwide. Neutrophils are the key host defense against these fungi. Routes of infection include inhalation, ingestion and traumatic inoculation. Mucormycosis cannot be transmitted from person to person, so there is no need for people to be isolated unless they have another reason. Types of mucormycosis: rhinocerebral, pulmonary, cutaneous, gastrointestinal, disseminated, etc. Risk factors. Uncontrolled diabetes mellitus. Neutropenic patients plus cancer. Receiving broad spectrum of antibiotics or immunosuppressive agents.
steroid طبعا.
Diagnosis. A high index of suspicion is very important. Suspected findings that need prompt immediate further testing include cranial nerve palsy, diplopia, sinus pain, periorbital swelling, orbital proptosis or ulceration or blackish discoloration of the palatal mucosa. Imaging. Paranasal sinuses CT scan for any bony erosion. High-resolution chest CT, multiple nodules, pleural effusion and the reverse halo sign. CT and MRI for orbit and brain with MRV. Histopathology and cultures, for definite diagnosis.
نخش على المانجمنت بتاع الفطر الأسود.
Management of COVID-19 patients with mucormycosis. Management of COVID-19 patients with mucormycosis, one necessitating a multidisciplinary team. 2. Control diabetes, reduce steroid, and discontinue immunomodulating drugs. 3. Prompt antifungal drugs and surgical debridement. A liposomal amphotericin B. Liposomal amphotericin B is the drug of choice. 5 to 10 milligrams per kilogram per day IV infusion for at least 4 to 6 weeks. Version 1.5, September 2124. Prevention and control of transmission of COVID-19 inside healthcare facilities.
ثانية بس عشان احنا ايه
B. Conventional amphotericin.
آخر حاجة دي.
A liposomal amphotericin B. A liposomal amphotericin B is the drug of choice. 5 to 10 milligrams per kilogram per day IV infusion for at least 4 to 6 weeks. Version 1.5, September 202. B. Conventional amphotericin B. B. Conventional amphotericin B in the dose 1-1.5 milligrams per kilogram may be used if liposomal form is not available. 4. Step-down oral therapy. After parenteral amphotericin B, step-down oral therapy by posaconazole or isovuconazole. AA posaconazole. The dose is 3 tablets twice daily on day 1, then 3 tablets daily. BB isovuconazole. The dose is 2 capsules 3 times, day for 2 days, then 2 capsules daily. Management of COVID-19. Prevention and control of transmission of COVID-19 inside healthcare facilities.
دي مهمة جدا يا جماعة.
General recommendations for prevention and control of transmission of COVID-19 inside healthcare facilities.
بين الطاقم الطبي بتاعنا.
1. Daily screening of healthcare workers and patients before entering the healthcare facility based on clinical signs. 2. Any healthcare worker appears reports to be diseased should be segregated until proper examination, management. 3. All healthcare workers are required to wear surgical masks during work hours. 4. Minimal number of healthcare workers should be present at the same time in patients' units to keep social distancing. 5. Restrict unneeded movements between departments. 6. Suspected or confirmed cases should take a separate route from other patients beginning from the facility entrance, and all facility sections should follow the same separation.
عايزين نفعل الترايج برضه.
7 suspected or confirmed cases should be isolated in a well-ventilated isolation room. 8 standard precautions should be applied.
مهمين جدا الحاجات اللي جايه
Hand
دي.
hygiene, cough etiquette, personal protective equipment, clean and disinfected environmental surfaces, sterile instrument and devices, sharp safety, isolation transmitted precaution, safe injection practices.
طيب هنخش على recommendation.
Recommendations according to the type of procedure. 1. Non-aerosol generating procedures. Standard precautions. Isolation precautions taken to prevent the spread of infection by spray and contact. The need to adhere to washing hands before donning personal protective equipment and immediately upon doffing. The necessity to adhere to donning personal protective equipment as follows. 1. Surgical mask. 2. Protect your eyes by wearing goggles or face shield.
الحاجات دي يا جماعة.
3. Long sleeve medical gowns, clean, non-sterile or sterile, according to type of technique.
والنظارات.
4. Clean or sterile gloves depending on type of technique. 5. Healthcare worker are not required to wear protective boots and protective suits during routine care of cases. 6. Extended use of surgical masks, gowns, eye protectors, and face shields can be applied while caring for COVID-19 patients in the event of a shortage of personal to protective equipment for the length of the work shift. 7. Always remember not to touch the eyes, mouth or nose with contaminated hands or
كلنا
use
بنغلط
gloves.
الغلطة دي إن إحنا نلمس إيدينا
8.
ونلمس
Always clean
مناخيرنا.
and disinfect surfaces.
طيب ماشي.
2 procedures that include tracheal intubation, non-invasive ventilation e.g. BiPAP, CPAP, tracheotomy, cardiopulmonary resuscitation,
الحاجات دي إحنا ما
manual
بنعملهاش.
ventilation before intubation or bronchoscopy, sputum induction by using nebulizer hypertonic saline. The healthcare workers must adhere to the following standard precautions. Perform procedures inside a well-ventilated room. Follow the isolation precautions taken to prevent the spread of infection through air and contact.
العائلات لما
The need
نروح
to adhere to washing hands
خلي
before
بالنا من
donning
أسرنا.
personal protective equipment and immediately upon doffing them. Donning personal protective equipment as follows. A high-performance respiratory mask such as N95 or FFP2 or equivalent, with the need to conduct a tightness test to ensure that there is no leakage. Protect your eyes by wearing goggles or face shield.
الفيس شيلد
Long sleeve medical gowns, clean, non-sterile or sterile according to the procedure. Clean or sterile gloves depending on type of technique. The extended use of a mask, medical gown, eye goggles, or face shield can be applied while caring for patients with COVID-19 in the event of a lack of personal protective equipment and for the length of the work shift. Care must be taken not to touch the eyes, mouth or nose with contaminated bare hands or using gloves. Always clean and disinfect surfaces regularly. Ministry of Health and Population version 1.5, September 2021.
يا جماعة كان معاكم دكتور إيهاب.
Treatment protocol.
أنا عملت أحاول أعمل المحاضرة دي علشان الناس تسمعها يعني وتكون مؤهلين إن شاء الله بإذن الله للموجة الرابعة، وربنا يحفظ يا رب بلادنا الحبيبة ويحفظنا جميعا ويحفظ أهالينا ويحفظنا من كل سوء. شكرا لكم يا فندم.